Good afternoon. Thank you all for tuning in. The topic for the day is sepsis and update. This is Dr. Ali. Objectives. In this topic, we'll cover introduction on sepsis, epidemiology, pathophysiology, background, in which we will cover saga of sepsis definitions, new sepsis. We'll also touch upon sepsis in pregnancy, a take-home message, and few questions. Introduction. Sepsis is a major public health concern because of its leading cause of mortality and critical illness worldwide. Epidemiology. Sepsis is an ever-present foe in the intensive care unit. According to the South African Journal of Critical Care, in 2018, sepsis and septic shock accounts for 11% of admissions to general ICU. Mortality exceeds 10% for sepsis and sits at 40% in patients with septic shock. Some survivors of sepsis face long-term physical, cognitive, and emotional disability. Some basic pathophysiology on the sepsis pathways. Basically, it starts from an infection that causes unbalanced immune reaction, resulting in release of mediators of inflammation and tissue factors that results in procoagulant state, causing macrovascular thrombosis and inflammation by consumption of coagulation factors. This then leads to vasodilation, capillary leak, and cellular hypoxia, which eventually leads to lactic acidosis built up and eventually death. Background. The word sepsis is derived from ancient Greek meaning rotten flesh and putrefaction. It was first defined in 1991 by the American College of Chest Physicians and Society of Critical Care Medicine as sepsis 1, with the following criteria. SIRS, Systemic Inflammatory Response Syndrome. They defined it as involving 2 or more derangements of the following: white count cells, respiratory rate, heart rate, and temperature. Sepsis, defined as SIRS with infection, and mortality rate was 16%. Severe sepsis was defined as sepsis with organ failure or lactate. Mortality rate was 20%. Septic shock was defined as sepsis with hypotensive shock, meaning systolic blood pressure less than 90. Mortality rate was 46%. Sepsis 1 definition was used for a decade, and then in 2001, sepsis was redefined by the International Sepsis Consensus Conference as sepsis 2. The definition was expanded and it included inflammatory parameters, hemodynamic parameters, tissue perfusion parameters. Down the line in 2003, they concluded that there was no evidence to support the change to the old definition, so we stick to sepsis 1. In that same year, Rivers et al. Proposed an early goal-directed therapy, a hemodynamic optimization protocol which advocated emergency departments to achieve certain hemodynamic goals. This achieved 16% absolute risk reduction in hospital mortality. The theory behind this was based on that sepsis was a circulatory insufficiency with an increased metabolic state that could lead to an imbalance between oxygen demand and delivery, resulting in anaerobic metabolism and multi-organ dysfunction syndrome. The damage or the impairment of microvascular network is key role in the development of organ dysfunction in patients with sepsis via impaired tissue oxygen transport. Hence, there is a physiological shunting at the level of microcirculation as a result of impaired flow, so the supply would be unable to meet the oxygen requirement. So the benefit to early goal-directed therapy was adequate global oxygen delivery. Components derived from the early goal-directed therapy were fluid resuscitation and central venous pressure monitoring, mean arterial pressure maintenance and vasopressor usage, central venous oxygen saturation monitoring and blood transfusion, and intravenous antibiotic administration early. Early goal-directed therapy then divided their protocol into timely bundles from the time the patient comes in. They divided into first 3-hour bundles, 6-hour bundle, and then reassessing the patient's status volume-wise and tissue perfusion according to the columns demonstrated here. Unfortunately, the early goal-directed therapy did not last long. Main reason being central venous pressure was the first and the most critical endpoint for the early goal-directed therapy and the 6-hour bundle. However, central venous pressure is unable to predict the hemodynamic response to fluid challenge, and keeping it more than 8 was associated with impaired perfusion, multi-organ dysfunction, and increased risk of death. After achieving central venous pressure more than 8 and keeping the mean arterial pressure more than 65, the final step of early goal-directed therapy was central venous pressure oxygen saturation to be kept more than 70%, either by blood transfusion or by dobutamine. However, blood transfusion in patients with HB more than 7 does not increase the central venous oxygen saturation or decrease the lactate level or improve the outcomes. Eventually, this led to a deadly trial shown here, and this increased the risk for renal failure, gestational dysfunction, and respiratory failure, and eventually death. Then came along the question of steroids, to use or not to use. The New England Journal of Medicine in 2008 published a study, the Corticus study, in which they proposed hydrocortisone therapy for patients with septic shock. In this study, there was no difference in mortality at 28 weeks between the placebo and the hydrocortisone group. However, the duration to reversal of shock was shortened in the treatment group. Therefore, steroids were only proposed when resuscitation and vasopressor therapy has failed to achieve hemodynamic stability, only in the presence of shock. They suggested continuous infusion because that lessened the hyperglycemia and hypernatremia, and then to taper steroids when vasopressors were no longer required, and hydrocortisone 200 mg daily was used. Between 2014 and 2015, 3 independent multicentral randomized controlled trials evaluated the early goal-directed therapy in severe sepsis and septic shock. These were Processes from the States, Arise from Australia, and Promise from the United Kingdom. All 3 trials confirmed that there was no survival benefit of the early goal-directed therapy compared to the usual resuscitation. Our journey of sepsis definitions continued, and the international consensus sat down for the 3rd time in 2016, giving us a brief but comprehensive definitions. They got rid of SIRS and severe sepsis, came down to sepsis and septic shock. These are the definitions we use up to date. Sepsis is defined as life-threatening organ dysfunction caused by dysregulated host response to infection, either suspected or confirmed. Organ dysfunction can be represented by an increase in sequential, that's sepsis-related, organ failure assessment, SOFA, score of 2 or more, which is associated with an in-hospital mortality greater than 10%. SOFA uses simple measurements of major organ function to calculate severity of the score. The scores are calculated 24 hours after admission to ICU and 48 hours thereafter. The mean and the highest score are the most predictive of mortality. SOFA involves 6 organs: respiratory, cardiovascular, central nervous system, renal and hepatic, and coagulation. The function of each is scored from 0, that's normal, to 4, abnormal, giving a score of total 0 to 24. SOFA was then simplified to Quick SOFA for bedside assessment. Lucky for us obstetricians, it consisted of assessing blood pressure, that's systolic less than 100, altered mental status, that's GCS less than 13, and tachypnea, that's respiratory rate more than 22 per minute. Score of 2 or more criteria suggested greater risk for poor outcome. Septic shock. Septic shock is a subset of sepsis in which underlying circulatory and cellular metabolism abnormalities are profound enough to substantially increase mortality to 40%. Clinical criteria included use of vasopressors to keep MAP more than 65, lactate more than 2, and this is despite adequate fluid resuscitation. Transfusion. Only when hemoglobin concentration decreases to less than 7 grams per deciliter. Mechanical ventilation using target tidal volume of 6 mL per kg to maintain plateau pressure less than 30 centimeters of water. Glucose control, maintaining glucose less than 180 grams per deciliter. This is a simple diagram which demonstrates the mechanism of vasodilatory shock. Tells us that when there is an insult to a cell, there is an increase in nitric oxide synthase, there is increase in lactate, and there is also increase in vasopressin secretion and decrease in ATP. All of these result in cascade of reactions which eventually result in vasodilation. Guidelines for the management of sepsis and septic shock are the following. Initial resuscitation, at least 30 mL per kilo of IV crystalloid fluid within the first 3 hours. After initial resuscitation, additional fluids guided by frequent reassessment, MAP more than 65, guiding resuscitation to normalize lactate in patients with elevated lactate levels as a marker of tissue hypoperfusion. Appropriate routine microbiologic cultures before starting antimicrobial therapy within 1 hour. Empiric coverage for all likely pathogens. Procalcitonin levels to support shortening period of therapy. Source control intervention to be implemented as soon as medically and logistically practical. Fluid therapy, fluid challenge techniques with continued fluid administration as long as hemodynamics factors continue to improve. Vasopressors, norepinephrine as first choice of vasopressor, adding vasopressin 0.03 units per minute or epinephrine as needed. Recommended against IV hydrocortisone if adequate fluid resuscitation and vasopressor can restore hemodynamic stability. We're still marking calendars. As time went on, things became much more clear though. The Surviving Sepsis campaign bundle updated in 2018. They have combined the 3rd and the 6th hour to form 1 hour bundle. These were 5 solid, easy to understand points. Number 1, measure the lactate level. Remeasure if initial lactate is more than 2. Number 2, obtain blood cultures prior to administration of antibiotics. Number 3, administer broad-spectrum antibiotics. Number 4, begin rapid administration of 30 mL per kg crystalloid for hypotensive or lactate more than 4. Apply vasopressors if patient is hypotensive during or after fluid resuscitation to maintain MAP more than 65. In the next few slides, we're going to touch on sepsis in pregnancy. Sepsis accounts for 15% maternal deaths and is among the top 5 deaths in pregnancy worldwide. Risk factors. Risk factors are classified into obstetric factors and non-obstetric factors. Obstetric factors include amniocentesis, cervical suture, prolonged rupture of membranes, prolonged labor, vaginal trauma, episiotomy, cesarean section, and retained products. Non-obstetric factors include obesity, diabetes, immunosuppression, anemia, and socioeconomic deprivation. Diagnosing sepsis in pregnancy can be very challenging. Reason being, sepsis parameters can be masked by the normal physiological alterations in pregnancy, as per shown in this table. Use of corticosteroids and timing of delivery is major concern in obstetrics. Sepsis is not an immediate indication for delivery. The timing of delivery in septic women should be individualized. Consider gestational age and maternal fetus. Evaluate the CTGs very carefully as it might show tachycardia, reduced variability, and decelerations. Improving maternal hemodynamics often improves fetal status. Cesarean delivery is reserved for obstetric indications, and corticosteroids for fetal lung maturity are not contraindicated. In patients with sepsis or septic shock, strongly consider avoiding neuroaxial procedures. The physiological status of patients with sepsis or septic shock is compromised. Cardiovascular effects of neuroaxial block techniques may cause further detriment with high potential maternal and fetal morbidity and mortality. I would like to conclude this talk with a take-home message. Use the quick SOFA, effective resuscitation, early source control, and early transfer to OCU will save your patient. Shukran.